You ought to see what the hell it does to you. The contraindications and the complications.
Psoriasis.
Yeah. Oh God, it's horrible. I got the damn thing at home.
How many cases?
You know what? After they stop it for about 3 months, so the damn stuff comes back.
The new medication.
And it's all kinds of fancy stuff. I don't know. Damn.
How many cases would you say that you've taken? Psoriasis? You've used autohemo on psoriasis?
Yeah.
About how many times?
I used it on the tough ones. I'd say I had about 4 good cases, 4 good ones. I mean, the real difficult ones.
And you used it on those 4. And did you get results in all 4?
Yes, yeah, improved. But they have to stay away too. You know, these things recur. Recur when they start to take some liquor, when they use. There are many things that happen. They neglect their scalp. See, the scalp, if you can clean up a scalp, you've got 50% of the psoriasis under control. Nuts.
How many autohemo injections did you use for the psoriasis patients? Do you recall?
No, I don't. I've got to see their charts. It's silly. I wouldn't guess.
Yeah. Your general course of treatment's been once a week?
Oh yeah, yeah, once a week would be enough. Up here, here's some beauties. Wow.
Autohemotherapy. And that this might, you know, in terms of like going like question answer, you know, on some stuff, and just see if I can get it. Okay. Just some of the questions I had about autohemotherapy was how did you learn about it? Of course you learned in medical school, but just in terms of like, you know, talking about that. How was it presented to you? Was it presented as a treatment of last resort? How did they explain it to you? Or, you know, when you went to medical school, when you first learned about it? And then how did they explain how it worked, and how do you think that it works, if it works? How long have you been using it? I just jotted down all these 20 questions. How long have you been using it, the numbers of cases, the types of cases, results that you've had, the most prominent types of cases, and then discuss what you know about its use in other countries. You know, you have people coming in from different countries. I'm just giving you a rundown. I'm just going to bounce from one to the other. And then the question of whether you thought that maybe would something like this possibly be of use in a disease like AIDS or other unknown diseases, and what would you know, just off the top of my head, what would you try if you had AIDS? Would you use something like this, or would you use these drugs that they have, or, you know? Anyway.
Well, I would try it on AIDS because of the. It depends on the patient. See, it depends on the patient whether you can tell them that we might try using your own blood, and you've got to go at it carefully. You don't know whether he has the ability to build up his own gamma globulin. See, basically he builds up his own gamma globulin. Now, I've read some of the reports. They throw in so many chemistries now. See, when you go into the chemistry of the thing, you get frightened because it's out of reach for me. I can only say it as a layman. I know I can light a fire by striking a match, but other people can start a fire with many other things. You understand? In other words, I simplify it. The man that's doing the chemistry, biologic chemistry, has so many different elements in the blood that he is able to explain his mistakes and what he doesn't find in relationship to the amount of things that he knows about the blood. Now, I don't know so much about the blood as they do, because I only know a few factors. There's about no less than 200 factors in the blood now that you can do things with, or they find now, or they're familiar with, or they render other things malleable. They mix them up. They're able to mix them up because they've got the formulas they know, and they've got the money that backs them up, and they stand around and do it until they find something. Then when they find something, the damn thing has no value because suddenly people get sick, very sick. I don't have the materials here. I think I have them at home. But when you start to read the complications that come in with all these new things, see, they had I think it was cyclamine or something like that, was a new drug that came out for psoriasis. Well, the goddamn stuff costs about $1,400 a month, see, just for medication. And now they're finding that it's doing a lot of harm in the complications that arise from using it. And if you don't use it, then the psoriasis comes back. And then they've just come up with something new. Oh, darn it, I forget where I read it. I must have it in my bag or at home. And it's such a complex subject that the ordinary guy, schmo, can't move in there, you see. Say, the only way I explain it to a person is, well, how's my own blood going to do anything for me? So I tell them that the blood circulates and it runs around, and all kinds of viruses are in your blood, and you also have so many protective mechanisms. And the only way you can get them together, the protective mechanism and the virus, is to make a collision. You put a puddle of blood in the muscle. Now they come around and they see who these strangers are that they never saw because they were always in motion, just like on a highway. See, so that's the only explanation, and that's logical. You see, they accept the logic of it because they've traveled on a freeway. You don't know who's next to you, ahead of you, or behind you, until you see a crack up, then everybody stops. Oh, geez, that's a such and such a car. That's a such and such a car. Look at the people in there. We never saw people before. Oh, we saw with drivers. You see, you don't see a person. So you begin to analyze it that way.
When you went to medical school, how did they explain autohemotherapy? Was
They didn't have it.
They didn't have it?
No, they didn't have it then. The literature was out, but they sort of backed away. It all depends on who was doing research in what organization, you see. If you went to a school where they were doing it, then you would learn about it.
And is that where you learned?
No,
at the school?
I learned it outside. You know where I took it up? When smallpox was taken away from the market. I used to use smallpox for herpes.
Okay.
Because it too
smallpox vaccine.
Smallpox vaccine. Then the government says, wait a minute, we don't have any more smallpox, it's not for sale anymore. You can't have it. We're storing it for that inevitable day when suddenly we'll get another epidemic break into the world. You see, because we're going to get away from our immunizations. See, we don't have it. Now the kids that are growing up are not immunizing against smallpox. Where are they going to get smallpox? Who knows? Because they're going to go to some foreign state in Africa and find that suddenly somebody's getting blisters. Jesus, it's not chicken pox. Gee, look at it.
So you couldn't get smallpox vaccine to treat what kind of cases? Or herpes?
Herpes, yeah.
So that's when you picked up autohemotherapy?
That's right. I figured that's the only thing left now to see what we can do. And damn if it didn't work.
Do you recall when you first heard about it?
About autohemotherapy?
Yeah.
Well, I was always interested in the goddamn stuff, so I must have read about it many, many times. I used to work with people that went out. I worked with men out in Philadelphia. We used to go out and hunt up the fly trap. The fly trap. I forget what the hell it's called. But anyway,
the plant?
It's a plant.
The Venus flytrap.
Venus flytrap, yeah. We used to go out and hunt that. Then they would render it to use as an anesthetic when they did muscle block or nerve block. There was a guy by the name of Judovic and Bates over there at the University of Pennsylvania. And I happened to be working with them too. That was the greatest thing you could do.
They used the poison from the Venus flytrap?
It's not a poison. It turned out, when they analyzed it, it turned out to be ammonium sulfate. Would you believe that? The basic chemical was ammonium sulfate. I still have the vial here.
And what did you use that for?
As a nerve block.
Okay.
We used to use it in, especially here, all kinds of muscle difficulties, like low back pain.
Okay.
First thing they did was measure him up. They stood the guy up. Sure enough, one hip is higher than the other. All he needed was a lift in his shoe. But to take care of it, they used that muscle block.
Okay.
And that was ammonium sulfate, better known as the pitcher plant. That's it, the pitcher plant.
Pitcher plant. And these guys, one of these guys used was familiar with autohemo?
Oh, they wrote articles on it. I got one of their articles here.
About what year was that, do you recall?
Oh, that, I was back there between 35 and it must have been about 1937, 38, because I didn't come out here till 44. I came out here in 1944. So I worked with him over there at the clinic. It was
Where was this?
at the University of Pennsylvania Graduate Hospital. Bates and Judovic, these two were very active in that. It was very interesting.
And then you were talking about your results with herpes. I interrupted you. You said.
Well, results with herpes simplex was excellent, especially, and then when we always called herpes simplex even was on the genitals. That's because before we started to get herpes virus 2, you see. Well, as soon as you got the electron microscope, you could tell herpes 1 from herpes 2 by the shape of the herpetic virus. That's when we did that. And then we knew that there was something else. Wait a minute, this is herpes 2. This guy is contagious. Herpes 1, you never got any trouble with people that had herpetic lesions. I used to give it to kids. It was amazing. Kids would go out skiing. I remember doctors' children used to go out skiing. Well, they were subject to herpes because they were in the wind and sunburn, you see. They got sunburn and windburn up there in the hills. And they were able to go out next year. And I had a beautiful case, although that case is, I think that I treated with smallpox. They keep their cards here. Isn't that interesting? One was Eva Rogers, and the other one was Mrs. William Gale. Now they moved into the east. Herpes simplex of the plantar surface. That's back in 1966. She came in here with an ulcer. I think I told you about that. She had an ulcer at the bottom of her foot. It only came out Christmas time. Christmas she got an ulcer in her foot. A plantar, like a plantar wart. 65 she came in. She was here. Her husband came in here in I don't want to tell you what we charged at that time because it's too much. I charged it too much. Anyway, the office visit, yeah, complete blood count, whatnot, and she got injections, yeah, number 10. The first time she came in 12, 66 blood count. Gail Williams. I said, come in October and we'll start some of these shots, and I think you may have it. And it was very interesting. We had an excellent dermatologist here. His name was Obermeyer. Obermeyer. A very an astute fellow, but he gave her up, and he said he didn't know what to do with me. So he says, anytime somebody finds out what's wrong with that foot, that it comes up only in Christmas. And it was an ulcer. See, it came up as a blister and then it ulcerated. So she wasn't able to walk for a month or two. It would start to come in just about the end of December, just around Christmas time, until it healed up. Took another month and a half. Well, he was lost. When she told me, I said, geez, there's only one thing that comes out in the same area. There's only one lesion that'll come out in the same area repeatedly, whether it comes out once a year or it comes out 4 times a year. I said, let's try this treatment. And damn if she didn't clear up.
Autohemotherapy.
No.
No.
It was smallpox.
Smallpox, okay, you're still using the smallpox.
Don't forget, this was back in 70. And 1968. God.
So you were still using smallpox. Well, were
Yeah,
you,
well,
were you using autohemotherapy then also, or no?
No.
Oh, so you're fairly recent as far as using autohemotherapy.
I'd say as soon as they stopped using the, as soon as they took the smallpox away from us.
It's more like the 70s.
Yeah, I started to use.
Okay.
There was nothing else left.
Okay, that's
But
interesting.
smallpox did the beautiful work on the herpetic lesions. But then I took it up with other things that just didn't work, like psoriasis. Get a good case of psoriasis. People get tired coming in. They don't want to come in. Who wants to pay $50 for a shot now? Over there, see now, when I first started to work with this woman, so the office visits were pretty high. It was $7.50 a visit. See,
American
money.
Yeah.
$7.50. That came up from a $5 visit. You start to be a specialist, so you charge $7.50. That's in the 60s and 70s. Oh no, I see. In '66, I started to charge $8.50. Wow, boy, she was really being taken. Tell you, these rates today. Well, you can't help it, see, because the overhead, the insurance rates. It's tragic. 64 years she was coming in 64, $7.50.
Still the smallpox vaccine.
Yeah.
Did she ever get autohemotherapy, this one? No.
No, see, she smallpox vaccine up to 71, see. She started in 66, she came in, but she always reinsured herself by coming in maybe a month or 2 before Christmas and getting another shot. The first year she got her injections, all she got was a red sore spot there. It didn't break through the skin of the plantar areas of the foot.
The plantar, is that the bottom?
That's the bottom of the foot that you walk on, yeah. That broke right through. She always had an ulcer there. It was so big, the blister that formed, see, the herpetic blister. Why the hell should it form there? You tell me. But that's what it was.
Yeah.
Did you do an electron microscopic examination? Didn't have any then. But that's all it could be. There's only one thing that you can recognize is coming out in the same area repeatedly. See?
Okay, now since
It's the same thing, yeah. Well, after they took smallpox off the market, then I started with the autohemotherapy. And I used it on various things. I still have a girl here that breaks out on her sacral area. One of the girls. I don't even charge her when she comes in.
I'll edit that from the tape.
Huh?
I'll edit that from the tape.
Oh. No, you can't charge her. The poor girl gets some awful breakouts. I don't know why. You want to call it worry? But they start to clear up once she starts to get the injection. But then she says,
"This is the autohemotherapy."
Yeah,
Yeah.
yeah, definitely. And then of course, Mrs. Rogers was she had hidradenitis suppurativa. And as I say, that was the serendipity case. See, that's a case where I was giving her radiation for some of the stuff, and the surgeons were cutting into her axilla. These were giant pus pockets.
And what did you do with her?
Huh?
What type of treatment did she get?
Oh, well, she developed herpes zoster.
Okay.
And at that time, we started to give protamide. Protamide was a beef enzyme. I gave her that. And after about 4 injections, my God, the poor girl cleared up. She said, you know, I'm losing my, my boils. I said, well, this is something new. And I wrote it up. Shit, I just had comes up in the shock letter. There's a small bulletin that comes out from the dermatologist. Wrote that up, and they looked askance at it. Didn't mean a thing. You can't sway them. You can't sway the people. It's so difficult to get them away from medication. Don't pick up words that I drop here and there, you know, out of disgust. Yeah. Oh yeah, here's the one right here. New drug targets psoriasis. A new immunosuppressant agent referred to investigatingly as FK506 has proven very effectively in the treatment of recalcitrant psoriasis and pyoderma gangrenosum. Well, gangrenosum pyoderma would respond to, I think, autohemotherapy, and the same thing with the papaya. Now, the drug is about 100 times more potent than cyclosporine A in terms of its immunologic actions, declared Brian Jegasathi. He's the such and such Department of Dermatology, University of Pittsburgh Medical School. Now, oh yeah, he said FK506 not only inhibits interleukin-2, but other cytokinins as well, such as interleukin-3 and gamma interferon. You see, these fellas are way out in the chemistry line. A receptor for the drug, an FK binding protein, is present in almost every cell in the body, he noted. FK506 produced dramatic results in 9 psoriatic patients treated at the university. All right, see now here, I outlined in yellow. All right, let's go back here. Now, all right, the university. All 9 people with psoriasis received a dose of 20 milligrams per day, so orally and divided into so-and-so doses. At 6 weeks, the dose of FK506 was reduced by 50% in 5 patients with psoriasis and the primary disease. Their disease relapsed immediately.
As soon as they stopped the treatment?
No, they reduced it by 50%, the dosage that they were getting. Their disease relapsed rapidly, and original dose was restored following relapse. It took longer for their disease to clear. He said that at times when patients were totally clear after 2 weeks therapy, analysis of the biopsy specimen revealed such and such, after the skin looked entirely normal clinically, there was still evidence of epidermal acanthosis, which took more than 6 weeks to return to normal on the original doses. Now, the same 20 milligram dosage was administered to 4 patients with pyoderma gangrenosum, so-and-so. Now, let's go over here. Now, Dr. So-and-so, Jigsafi, and colleagues found that the side effects of FK506 fall into 4 categories: neurotoxicity, metabolic effects, hypertension, and nephrotoxicity. Neurotoxicity and metabolic side effects that occurred were minimal and transient and posed no problem, he said. Unlike cyclopropene A, this drug did not cause any hypertension. The only troubling effect was in relation to kidney function. Didn't cause anything, just kidney function. Every patient had an increase in serum creatinine, anywhere from 50% to 200% greater than baseline. However, as soon as the dose was reduced, the serum creatinine returned to normal. Despite this increase in serum creatinine, very little or no change in renal plasma flow or creatinine clearance was seen in any of the psoriasis or pyoderma gangrenosum patients treated, he pointed out. Dr. Jegasafi said that the half-life of FK so-and-so is about 7 hours. That is, it metabolizes mainly in the liver. Its absorption, he noted, can significantly affect by other factors, notably concurrent administration of other drugs. When given along with an antacid, for example, there's a significant decrease in the absorption of the drug. 2 patients with Cedars syndrome had dramatic initial response to FK506, but both patients experienced recurrences when the drug and subsequently died. These cases, as well as as effects other than those on interleukin-2 produced. FK506 may have been the source of are the source of continuing investigation. The second generation version of the drug, which may avoid problems with nephrotoxicity and even more effective, might be available for testing later this year, he recommended. They get into so much trouble with these drugs. And the price of them, down in this world, they can use autohemotherapy. But who the hell wants that? What am I going to do with the medicines that it took me so much money to complete?
So psoriasis, you've treated psoriasis, you've treated herpes.
And vague cases of, I'd say, urticaria, that you couldn't figure out what the hell it was all about.
Okay.
Vague cases you couldn't find unless you, well, they'd been to allergists already. They'd already been to allergists. And they weren't unable to sort of solve the problem. I can't find anything that really is causing you all that trouble.
Do you have any idea, like, over the years now, it's been almost probably 20 years since you've used autohemotherapy. You've been using it for 20 years. Like, roughly how many patients, do you have any fix on that, that you've treated with, you've resorted to autohemotherapy?
Oh, but I've treated at least 40, 50, or 60 patients.
Okay.
At least.
Yeah. Okay. And okay, so it's basically been psoriasis, herpes zoster, urticaria. Are there other types of
not herpes zoster. Herpes zoster, herpes simplex.
Okay.
Yeah.
Urticaria.
Yeah.
Those are the main categories.
Difficult urticaria.
Okay.
I mean, I just get the cases that they had no solution for them.
Okay, and if we could go down, those are the main categories, you'd say, of diseases that you treat.
Would be the main category.
Okay, and have the results been uniform for all three of the types of diseases? Maybe we could discuss them one at a time, like your impressions of psoriasis.
Oh, they improved, yeah. I mean, the patient knows it right away.
Okay.
They notice it, yeah.
And all three, have you had sort of uniform results, or have you had better results with psoriasis than with
psoriasis is a very difficult thing, because if the patient drinks liquor, he's going to not permit his psoriasis to clear up.
Okay.
And they're starting to mention it now in the literature. And if he doesn't keep his scalp clean, when I see a psoriasis patient with a bad scalp, I say, boy, I'm going to improve you 50% if you do what I tell you. And that's cleaning up the scalp with letting the tar shampoo sit in that head of his for some time. The fellow I cleared up from Taiwan, he couldn't get over the fact that with the tar baths, which he didn't have over there, and he had a little bit of, he got ACTH, which is adrenocorticotropic-like hormone. With that, he started to get better. He cleared up the face. His face and neck and head cleared up and permitted him to stay here about 4 or 5 weeks. More longer than he expected, because he was getting better. Now it's about 8 years since he's been treated. And that guy keeps himself very well clear of psoriasis. The last time I saw him, he had a few spots on his legs. Well, who the hell cares about legs?
Did he get autohemotherapy also?
No.
No. Okay.
No, he didn't. Because he started to respond to the ACTH, and he got that injection, and then the tar baths. And I told him about staying away from wine or liquor, and cleaned up his scalp. See, his scalp was broken out just like the rest of his body. But once he got tar into his head properly, then he started to clear up. And he's remained, I'd say, oh God, I don't think he has 10% of what he had originally left, but he doesn't mind a few little spots. He knows what to do with them. There's so much tar preparations on the market now that keep it under control.
You mentioned herpes simplex.
Yeah.
You've used
and herpes. Yeah, I use it also.
Autohemotherapy.
Yeah, not only herpes simplex, but herpes number 2.
Is that herpes zoster?
No, herpes 2 is genital herpes.
Okay.